anemia beyond iron deficiency, and I think it is very well required because of late I'm seeing a lot of patients who are being given parenteral injections without actually evaluating. So the kind of a spectrum that we find these days is a woman is referred to you after giving 1,000 milligram of FCM, and then she comes back to you with a lower hemoglobin, and that's the way. So I'm just going to put up a very practical kind of an approach which will allow you to think in maybe 6, 7 steps as to how we are going to go and at what point we are going to call somebody else to come back and help us. So iron deficiency beyond, and beyond, what are we going to do about it? Now, just to give you a perspective of anemia, nature gives us 9 months. She comes to you in the 3rd month, we have another 6 months. We have to make sure that by the time we reach the delivery time, we have to correct her anemia, evaluate, and make sure that she has that reserve. Anemia per se is defined, we all know what the definition is, but when we talk about the etiology, we are 3 broad categories. Is there a reduced production of erythrocytes, or is there a loss which is occurring somewhere, or is there a destruction, or a combination of any one of them? I'm just going to take a very simple case, 9.3 grams hemoglobin, but if you take a look at her indices, MCV is 70, 20, and MCHC is 29. Easy to remember, less than 80, less than 25, and less than 30 is very crude way of remembering, but invariably they'll give you the normal range, not much of a change in pregnancy. Now, if you take a look at this spectrum, RDW is more, that is more than 14.5. Then we come back again to those 3 main questions. What are the factors that are affecting the production over here, or is she losing blood, or is there any evidence of increased breakdown? So 3 main areas to go through. The starting point, and all of us have to start asking, is leave hemoglobin percentage alone and ask for a complete hemogram, because it gives you so much more information. Not only does it categorize the severity of anemia, but it also gives you the MCV. And based on the MCV, that is the mean corpuscular volume, we will classify it as microcytic, less than 80, 80 to 100 as normocytic, and more than 100 as macrocytic. The red cell distribution width is given invariably these days, but if it's not done, all we have to ask the lab is to print it out or give a small slip which comes from the cell counter. So these are very important first starting point of evaluation. So moving across to the microcytic part of it, the algorithm would be, if the RDAW is high, more likely that it is iron deficiency anemia. And if it is normal, then it would be, you can have chronic disease anemia, thalassemia, or any other hemoglobinopathies, or any other cause that might be there. The second point that we have to remember is that high TIBC would be, that is total iron binding capacity, would be there in iron deficiency, and a low total iron binding capacity would be there in all other ones. So if you find it difficult with high RDW, where are we and what is it? Go for the diagnostic test. These algorithms are important because we can't write a panel of 20 tests immediately at the first time we see. So we go one step down and say that what is it and what is the next test that I'm going to. Now, RDW, what happens in iron deficiency anemia is that you have increased production and the RBCs are of different sizes. So if you put all the sizes side by side and you find that the spectrum of the size change is much more higher in iron deficiency, whereas in thalassemia, what you find is the sizes are similar to each other, and that's why they're all clubbed together at one spectrum, and RDW is less. So this is something that we all should remember. Now, differentiating IDA and thalassemia, we have another called as Menzer's index. You take MCV and divide it by the RBC count, and you get 13. Okay, more than 13 is iron deficiency anemia, less than 13, again a bedside tool that as students you can teach. But the diagnostic or the screening test that we use commonly is the hemoglobin A2 levels, and by doing a HB electrophoresis or HPLC. And if it is more than 3.5, like in this case, you find it at this point 4.9%, and we call it as thalassemia trait. You do the partner screening, and depending on the gestational age, counsel further. But it is our responsibility to go for the step 2, which will be the hemoglobin variance estimation. Now, moving back to the first case that I was talking about, she 9.8 hemoglobin, Ferinject given, and then referred back to you with 9.3. Her indices, if we take a look, it is microcytic again. But when we do an HPLC, you find that this is sickle cell trait. If the sickle cell hemoglobin is more than 80%, or more than 90%, then that is sickle cell disease. But when it is in combination with adult hemoglobin and sickle cell, both of them together in a varying, we call it a sickle cell trait. We have a huge number of women who still struggle with these diseases, and as an obstetrician, our responsibility to diagnose. So I would like to stop at this point of time and say that, one important learning lesson: never give parenteral iron without evaluating, never give blood transfusion without evaluating. Okay, serum ferritin is the one that I use, but you can use other ones also. But hemoglobin variant estimation should become a mandatory part of baseline antenatal screening as our responsibility to that woman who has come for antenatal care. Now, moving across from this to further down the line, this is a woman at 28 years, 8 weeks gestation, has suddenly come out at 2.9 hemoglobin, breathless, admitted into the ICU. And if you take a look at the indices, very surprising, you find that all the indices are normal. The third step is look at her other cell lines. The other cell lines are also normal. You find the platelets. Now, the algorithm for normocytic anemia, the next one is retic count. If the retic count is normal, all indices are normal, she's bleeding acutely somewhere. Not much time for them to change. Now, if it is more than 2.5 retic count, it is a hyperproliferative state, can be in chronic hemorrhage or in hemolytic anemia. Or if the reticulocyte is less than 1 or 1% or 2.5%, then we call it hyperproliferative. It can be leukemia or aplastic anemia or any bone marrow disorder. This was a Mallory-Weiss chair because of excessive vomitings and acute intestinal bleed, and we had to do an endoscopy to control that bleed. Very importantly, in pregnancy, there are certain times where we come across concealed hemorrhage, and it is abruption, rupture uterus, percreta, sometimes bleeding out, liver hematoma and bleed, splenic rupture and bleed. We have a maternal death because of splenic rupture. Now, moving from these three steps, the next steps would be a stool examination for ovarian cyst and occult blood, renal function test, liver function test, and thyroid function test, because they all have an association with anemia. Moving forward from here, the next case would be a case 4. This was a very sick case, 24 weeks of gestation. She came to the emergency room with fever of 1 day and inability to move the left upper limb. If you take a look at her vitals, pretty okay, 99.3, and on examination, we did not find any neurological deficit. Her hemogram, 6.3 hemoglobin, indices are all still normal, but her platelets have gone down to 15,000. So over here, WBC is still maintained, but RBC line as well as the platelet line has gone down, and fragmented cells are seen. So the step 3 is other cell lines. We have another cell line being involved over here. Now, the next point is always asked, do you have any reports that have been done in previous time, CBP? And what we realized was all her CBP reports were absolutely normal. She has a HPLC report which said that absolutely fine, hemoglobin A2. Now, she had evidence of hemolysis. LDH was very high at 807, which then moved over to 1800. She had facial palsy, which was seen by the team, documented by the team, and then disappeared after some time. MR venogram was done, which was normal. We did the step 5 for hemolysis, that is LDH, bilirubin, and peripheral smear here, and then moved forward. She worsened over a period of time. We shifted her to a higher center. Hemoglobin dropped, platelets dropped to 4,000. At this point of time, we did the ANA, bone marrow biopsy, no response to steroids, gave immunoglobulin, no response, plasmapheresis was started, then she started improving. So putting down the list of the causes of anemia, nutritional, we have ruled out, hemoglobinopathies, we have ruled out, hemorrhagic anemia, we've ruled out, we have done an MR venogram, hemolytic anemia is where we are standing at this point of time, bone marrow we have tested, and we had an ITP-like response. So this is something that tells you that hemolysis is a part of the evaluation of anemia, and looking at the urine many times gives you a kind of idea. Hematuria is definitely red in color, but hemoglobinuria is cola-colored. The minute a pre-eclamptic patient or anyone develops this kind of a very light tinge, and you can just have your alertness up in the ICU. And absolutely brilliant way of picking up that she's going for a hemolysis. So what was our diagnosis here? Gestational thrombocytopenia. She has anemia coexisting. Less than 60,000 is not usually. hemolytic anemia, but we have some other cell line involved. Is it ITP with hemolysis or is it Evans syndrome? And it can be SLE with ITP, hemolysis, and vasculitis, so it comes across. Now, two important conditions, renal function being normal rules out TTP and HUS. So we came across to a kind of a conclusion that maybe we're looking at Evans syndrome, secondary maybe to SLE that we have picked up for the first time, and we managed, and she went on to 36 weeks to have a delivery. At this point of time, I don't want to go through it. Dr. Sunil has already mentioned, but three conditions that obstetrician should keep at the back of my mind. One is PNH. The second one is TTP. Okay, very lethal conditions, very high maternal as well as fetal mortality and hemolytic uremic syndrome. The next part that I'm going across is all the cell lines are affected. When it is so, B12 deficiency, yes, keep it at the back of your mind, but then bone marrow suppression can be a possibility. Drugs can be a possibility, infections can be a possibility, malignancies and leukemia. So this is something that we end the part of it. Now, one important thing that I have left off is macrocytic anemia. Macrocytic anemia, the algorithm goes down. Do you have segmented neutrophils? If they are segmented neutrophils, it is B12 or vitamin folic acid deficiency. But if segmented neutrophils are absent, alcohol abuse, myelodysplastic syndrome, congenital bone marrow disorders, again, bone marrow would be the essential test that we will be asking. So important at this point of time to do an assay, and if you find very easy to get a vitamin B12 or a folic acid assay that we can get it done, but at this point of time, sometimes we find hypersplenism as a cause of all the cell lines being suppressed. So do get an ultrasound abdomen to find out how is the liver and the spleen. So MCV-based classification of anemias is a very handy, very easy to follow kind of an algorithm. Each one of us can have this little chart in our OPD or our places of work and follow it through. So I would like to end by saying that all anemias require a focused approach. Sometimes we reach iron deficiency anemia very early, sometimes we have to go down further steps, and sometimes we have to call for a multidisciplinary involvement. But the take-home message from this session should be that not to give parenteral iron without confirming that it is iron deficiency anemia, that we should do a universal screening for HB variants. It is high time that we have 700 rupees is not very costly. Get that as part of our protocol for screening for anemia in all antenatal cases. So thank you so much.